The patients trust us to take care of them, and we have to be competent, confident. Hopefully we in the education department guide them in that.
Hi, I'm Dr. Keshishian. Welcome to our podcast series, House Calls with Dr. K. During this series, we're going to talk about many different things, but specifically, it's about medicine, the human side of medicine. We all have questions about our health, and who can you turn to? The providers that you trust. Hi, I'm Dr. Keshishian, and welcome to House Calls with Dr. K. Today's episode, we're going to be talking to the Nursing Education Department for LAC+USC Medical Center. We're joined by Tammy Blass, Deborah Hunt, Samantha Nguyen, Maybeth Franconi, Stephanie Capps, Julie Wolfson, and Michael Puckett. Hi, everybody.
Hi.
There are many people that don't really understand and know what the Nursing Education Department does unless you have been taught by one of you, yours truly, right? Tammy, I'm wondering, as the former director who just recently retired, congratulations. Can you give us a little bit of the highlights of what your team does?
Okay, my team or our team does a lot, and I think you're right that a lot of people don't realize what a gem they have in this department, if I do say so ourselves. But we provide all of the mandatory education, so there's that you would expect, orientation, that kind of thing for all the nurses. But we also have some really wonderful specialty programs. Our ICU program, our ER program, and our psych education as well. So we have a lot of really great programs that everybody's going to talk a lot about, but I think one of our really wonderful qualities is that we respond to whatever the medical center needs. So I think that's our greatest strength. So we're busy doing all these many programs that keep us very busy, but when there's, say, something comes up, like say a pandemic or something, then we're able to respond. They contact us right away and say, we need your help. So we're gonna need redeployment classes, and we need them to be not too long, but we need them to have everything that they would need to be prepared to go work in the areas, people that have been gone for a long time. So that's something. During the pandemic, another thing that came up is, okay, so now we're gonna need to expand the areas that are going to provide high frequency nasal cannulas, but we have nurses that have never been trained in that. So then we, our educators go ahead and come up with training pretty quickly, but is very detailed and very much prepares the staff to do that. So that went on throughout the pandemic. We have registry coming in tomorrow. I would get a text in the evening. Tomorrow we're going to get more. Can you take them? And of course we did, and we figured it out and everything. So this has gone on throughout the pandemic. I think in early May, we had trained, I think it was 550 for redeployment, many of whom had been away from the bedside for a long time. But then we went on to train many more, so I would guess it was probably 700 or 800 by now. So those are, I think, some of the things that we do. And then, of course, as I said, life support classes. I could go on and on about all the different classes we teach, but I think our real benefit to the nurses and to the patients and to administration is our ability to respond quickly to whatever they need and just adapt.
That's great. I have a question for all of you. You all sent me beforehand just a little bit of information about yourselves. I calculated the number of years experience amongst this group. Does anybody want to take a guess of how many years experience total that you have? Yeah, take a guess.
It's a few hundred years.
Yeah, it was over 150 years.
Wow.
Over 150 years of nursing experience.
Which is amazing because we're all only in our early 30s.
That's right. How did we do that?
Is that new math?
Now, your team consists of how many people?
We now are when we're full, we're 13.
13.
During most of the pandemic, we were anywhere from 10 to 12. But now, and this last part for the big surge, we just had 10. But we've now recently hired 3, so we're full. And of course, now I left as of the end of February. But in terms of the educators, we have 13 now.
And it sounds like you have the major programs that probably came into play most during the pandemic were the emergency nurse training program and the critical care ICU programs. Is that correct?
That's correct.
Were you training nurses for all of the Department of Health Services?
You want me? I'll go ahead and answer.
Yeah.
We provide all of the didactic critical care education for all the nurses in DHS. And even like for example, we had run our programs, and the one program ended at the end of October, and we didn't have another one planned until January. We ended up running one in November just for the other facilities who needed to train some more nurses. So even when we don't need nurses or don't have nurses ready to be trained here, we still train them for the other facilities as well.
And now, Deborah, you have taken over as interim director. How does that feel?
Well, it's been 2 weeks. So you can ask me in a couple of months, but it's been very good. It's been enlightening knowing everything that Tammy dealt with from day to day, like stuff behind the scenes that she just takes care of. And as an instructor, we don't see it.
Yeah.
So.
And now, Tammy, you've had 30 years experience.
Yes.
That's quite a bit of time.
Yes.
Since age 1, it sounds like.
Right, I know. So yeah, just right out of the womb when I was nurse. So my background is I had always been interested in, for sure, the medical profession, and I thought about nursing, but originally I thought I might go the paramedic route. And then while I was taking a medical terminology class so that I could give better reports while I was an EMT, the professor said to me, you should consider going to county nursing school and being an RN, because she was an RN and she was class of 1937. Wow. In fact, her picture is on the wall over at the college.
Wow.
And so I did, and I took a bunch of friends along with me from Pro, and we came to nursing school here, and then the rest is history. I've been here ever since, and I loved my time at county.
And you've worked in different areas.
So originally I was a burn ICU nurse. So I worked there, and then I came to EdCos, to nursing education, and about 24 years ago. And then the first half of it was as an educator, and then the last part as the director.
That's amazing. That's amazing. And Deborah, you have an interesting history yourself.
Do I?
You do.
So I worked, my mom was a nurse, and she encouraged me to go to nursing school when I thought I was going to be a PA. She's like, no, you don't want to be a PA, you want to be an RN. So I went to County US, here, LA County, and I went to nursing school. And then I graduated in 95, and then I was hired to work in the surgical ICU. So I worked in the surgical ICU for 7 years, and then I was going to school, getting my master's degree, trying to decide what I wanted to do, and I decided I really liked my clinical instructor, Tammy. Like, that was pretty cool what she did.
To say that.
So I decided to apply to the education department, and I was hired, and that was 17 years ago.
Wow.
Yeah.
Wow. And now we have people here, nurses here, who have trained people for the ICU, for emergency, for psychiatry, lots of different skills. And Samantha and Maybeth, you are part of the ICU coordinators, correct?
Correct. Yes.
Can you tell us a little bit about yourselves?
Well, I started off as an ICU RN, straight out new grad, at Harbor UCLA actually. And I got my ICU experience there, venture out a little bit to, UCLA, also UCI, and some of the community hospitals as well. So overall experience, I'd rather come back to the county. I love the patients and the type of, being a teaching facility, I really enjoyed it. And my coworkers are kind of like my family, and it's nice coming back. And I know the bottom line is I always want to be an educator, so I've always tried to pursue that route. And teaching nursing is one of the best things I ever did. I just love, just having that impact on the students and how I could, share my experience with them and teach them, and hopefully they able to use that information to actually, take good care of the patients. So I was very lucky to be able to join EdCos in 2013, and since then, this is my new family, and I've loved it.
I've been with the county. I started off as a student nurse worker in 2000, and then I worked with Deborah and Mike in surgical ICU 9300. And I went back to school to get my bachelor's. And I really didn't think I was going to be an educator because I was like, oh, I really love the ICU. And I still, we were redeployed and I still love the ICU. And actually Beverly, she's our former colleague, she's like, why don't you apply? And I was like, I guess, sure, I'll give it a try. I applied and it was such a blessing. I think all the steps in my life I feel like have been little blessings, you know. I actually didn't plan to be a nurse either. Fell into EdCos, and I'm so fortunate to be here. So I've been here for 13 years, I think. Is that right, Tim?
Yeah.
13 years, yeah.
Wow.
Now, just for the listeners, not all ICUs are created equally. I mean, we just talked about burn ICU and the surgical ICU, right? And ICU, medicine ICU, right? Pediatrics ICU. We have lots of different ICU intensive care units. Can you explain to us the differences in the skill level and the training, and how do you go about, choosing that path?
I honestly feel that you have a personality that matches an ICU that you belong to. In fact, when I first started, Cindy Clater, I was sitting in class and she says, where are you going? And I said, surgical ICU. And she says, oh yeah, you look like you belong in surgical ICU. And it's funny, you kind of fall into a personality of being a medical nurse, a pediatric nurse, a trauma nurse, a cardiac nurse. And I always say in my lecture that I am not a cardiac nurse because I couldn't tell you an S1 from an S3. No, I can't tell you an S1 to an S2, but it's a different monster, and it's all different. But I think you fall into a personality going into a specific ICU. I don't know if you guys agree.
Oh, yeah, I agree.
For sure. When I went to Burns, I was also a student nurse worker, and went up there as a student nurse worker, and instantly felt like, okay, this is home, and never thought about another ICU after that. It just Burns was it's a small unit, very tight-knit, kind of like how EdCos is too. And what I love too is that the patients are there for a long time, so you really get to know them and their families. So they're in the ICU and they're often on the ward for a long time. They come back to clinic. We used to even have a Christmas party where they would come back for the Christmas party, so you'd get to see them, and they still have a burn survivor party every year. So you get to develop these ongoing relationships, and it's really it's a special place to work. So I love my time in Burns.
Julie, what about you? Can you comment on the pediatric side?
From the it was really by default, because it's default that I'm a nurse, really, because I really wanted to be a teacher. But my mom, I'm half Mexican and half German, and my mom, she, without really knowing, I don't even know how she knew, because she didn't grow up here. And she came from a tiny village in Mexico, and so she said, no, it's better if you become a nurse. And I was like, oh, I don't really want to be a nurse, but okay. So I went into nursing school, and I remember my very third semester, I came home and I said, that's it, I'm quitting. I'm never going back. And she was like, but you're almost done. And I said, but I don't like it. And then for my fourth semester, I got to do my clinical here at County, and I was like, wow, what is this place? And it was just so fascinating with the patients, and I really felt connected to the patient population. Speaking Spanish and the cultural ties, and they really needed help, and I was like, this is it. And my very first patient I had was a HIV/AIDS patient, and he was so young, and he had nobody, and people were scared to go in the room, and I said, I'm not scared, I'll go. And I went in there, and I loved it. And so then I was in neuro. I came here as a student nurse worker, and they would always send me on 5300 in the ward. and it was complete total care patients, and it was hard work, but we were, as a team, it was amazing. And so then I went to neuro ICU, and then whenever we got a little kid, they would say, Julie, today you only have one patient. And I'm like, one patient? That's not the norm. And they're like, oh, it's this little infant that fell out of the window. I'm like, oh, great, you know. So I was terrified. But then I was like, okay, I'm doing this. And then I said, I want to know more about kids. So I went to pediatric ICU. And it was, you know, I pretty much stayed there in the ICU, traveled around county. I did California Children's Services, maternal child adolescent clinic, and then just went back to the ICU, and then came here to EDCOS for 6 years now.
Talking about working in the ICU just in the best of times is very challenging, because patients are very sick and it is a high stress environment and things can go wrong, and it can actually be really sad as well as, you know, extremely happy if there's a good outcome. How do you think, just in your own experiences working, you know, at the bedside in the ICU, and some of you were deployed back to the ICU during the pandemic, can you talk to us about what it's like being an ICU nurse?
You know, I have to say that being a trauma nurse in the ICU for that many years, there were a lot of sad stories where the patient didn't make it, but there are a lot of good stories where you healed the gunshot wounds, you sewed up the leg, and they walked out of there. When I got redeployed in the November, it was really sad because there would be like 3 deaths just in our little unit in one shift. And that was very different for me. And also I felt like I could do more for my trauma patients versus COVID. Once they were on that path, kind of circling down, I felt like there wasn't a lot I could do. So I do remember there was a 41-year-old gentleman who the family had decided to not withdraw care, but like take the ET tube out and let him pass. So 45 minutes I was in the room, I held the iPad to his face, and the family watched, and I held his hand, and they watched every single breath that he was taking, and I could tell they were looking at me too. So I was, you know, like rubbing his head and holding his hand, just so they didn't know that he didn't have to die by himself.
Yeah.
And then once he took his last breath, I put the iPad on the screen to show that it was a flat line, and the family just started wailing, and I was crying. And that was my introduction to being back in the ICU with COVID. Just dealing with rolling another iPad into another patient's room for the family to visit.
Yeah, it was very challenging. I was with Deborah in the surgical ICU, and we were. I was also redeployed to PACU, which was a new unit that they opened for the surge, and I had been away from the bedside for 13 years, which is a long time. And I think people think, oh, you teach the ICU program, you can do, but it's not so. You know, we're not used to the charting, not used to the day-to-day in and out. I mean, I had to learn how to hang up piggyback again, you know, because it was different from when I had practiced back then. So it was a lot of relearning. It was stressful, I'm not gonna lie. It was stressful to be redeployed back, relearn things in a different way. And then on top of that, you throw COVID on top of it, and it's like way complicated, you know? So it was a challenging time to be an ICU nurse, to be a redeployed ICU nurse, and then to work during a pandemic. It was not easy. I think it affected my family life as well, because I had young children. So my work days were spent not seeing them. And they're, you know, then they're like, are we gonna see you tomorrow? How many more days are we gonna see you? So that was a challenge. But you know, I, like Deborah, I mean, I love the ICU. To my bones, I love the ICU. And so to go back to my SICU family was great. I think the great thing about being a county nurse is the camaraderie, the family that you develop. I mean, we all have different families, our PICU family, our burn family, our SICU family. My SICU family was still there. So they took care of me, you know, and we banded together during this difficult time. it was hard for me, but it was hard for them. And some of them had been going through it since March, since a year ago, you know. So I think it was just nice to be together. You know, it was nice for us to be together during a difficult time, you know. And I think our skills come back. People say it's like riding a bike, well, it's riding a hard bike. It was not easy.
And you fell off a couple of times.
Yes, I did very hard.
Put those training wheels
Yes.
around.
Riding a unicycle.
Yes, that's what for riding a unicycle. But coming back to your county family and knowing that, you know, they have your back, like our family here too.
Stephanie, now you're talking about educating the emergency room nursing staff, and that was its own beast, especially during COVID. Can you maybe talk about your experiences?
Yeah, during COVID, it was a unique situation that really we weren't 100% prepared for. And like a lot of specialties, there's certain considerations in the emergency department that we have to always keep in the back of our minds, because we are essentially the front door to the hospital. And so a lot of the times we won't know or have the luxury of knowledge what we have to be careful for, what we're treating. So it was just really bringing everybody up to speed and making sure that everyone was using the precautions. Because as an emergency nurse, you see a patient coding, your first instinct is to run in that room and jump on, because you know it's such a critical time to get that patient back, and to then now have to take into consideration that we can't do that. We have to protect ourselves first. And so there was a huge learning curve, and it really almost went against the grain of what is embedded in an emergency department nurse. So it was, you know, making sure that the staff was taking care of themselves and staying safe, but then also bringing new nurses into that environment and trying to be cognizant and aware that they are new. They still are, you know, developing and acclimating to the culture. And so to not overwhelm them, but it was also gave them a chance to be like in certain situations with frequency that they really developed their skills so much faster, and having to see super, super sick patients very early in their career, and to live through the pandemic and, you know, be trained as an ER nurse when it was so crucial. So it presented a lot of unique challenges for the existing staff to give them the emotional support they needed, but then also integrating the new staff and making sure that they were safe and not being completely overwhelmed by a scenario. You know, because it can be very chaotic on its best day, but then you throw a pandemic on top of it, and it could just very easily crumble off from underneath you.
Well, I think you bring up a really interesting point about the emotional support, right? In your roles as educators, that I'm sure came into play when you are trying to retrain or train new staff into these new roles during a pandemic. And, you know, if you are a nurse that hasn't been at the bedside for a few years, there's probably a lot of anxiety involving that. Or if you're a new nurse and now you're like, okay, jump in there during a pandemic, that has a lot of anxiety. Or even if you've been practicing nursing for 30 years, it is a different way that you are doing it today. So how did you find that your sessions, your classes, your learning environments had changed, and how had your students changed?
So speaking for the pediatrics, it was they were going to the adult units because honestly our pediatric population has decreased. And so here there were extra nurses that only dealt with peds, and we know peds is very special. And so all of a sudden they were like, well, we have to go to adult setting, and we've never been in adult settings, and it's a different beast, adults versus pediatrics. So it was high anxiety, and Tammy being our leader, you know, and then everybody else jumped in too, and we held like a very specific cross-training things for them, and mostly having them to verbalize what were their fears and how could we you know, mitigate those. And so we developed a little program for them, and throughout the whole time always made aware that we're here to support you, whatever it is, whatever you need, we're also here. And I think we heard how the nurse manager, Roberta, was very grateful. So I know that speaking from pediatrics, that's how that went.
I know too, we were doing the classes early on for the clinic nurses that were being redeployed. And, you know, they were nervous. You know, some of them would tell us kind of the same story. It's been 27 years since I've done inpatient care. And they were going to be redeployed to assist up in the wards, you know, assess the nursing staff there. And by the end of the class, you know, we did like an 8-hour class for them. They would come up to you and they would be like, oh, thank you so much. I feel better. Like, it really was, I don't know, there was an emotional support component to it. It wasn't like we're just going to throw you up there and good luck, you know. And it was just reviewing chest tubes and tube feeding and Foley bags and all these things that they were nervous about. And I think they really appreciated it. Like that definitely helped. That was a good call.
Well, I think that is one really good example of how empowering education is. And I think that's the thing that kind of gets missed. And that's why I appreciate you highlighting our department, because it can really, really empower people to feel confident to walk into that unit, to go into that patient's room, because they do feel more confident after they've had education. And it doesn't have to be something extensive. It could be that 1 8-hour day. But us showing that we believed in them and that we were going to spend our time giving them the knowledge to support their practice kind of got them, you know, headed in the right direction and would hopefully charge them up and give them more emotional support.
I remember, you know, when I taught about 10 years in the ICU program, and one of the things I would share usually with my ICU students when we started clinical, I would share, you know, many years ago when I was walking from the parking lot, I said this prayer: please don't let my patient die today. Please don't let my patient, and you know, and they're like, really? You felt that way too? Like, it's kind of like we all realized we all went through that, and we all felt that anxiety, and it was through working with your, you know, instructors that kind of like bring you along that you survive that, because yeah, it could be paralyzing otherwise.
You know, it's so funny that you say that, and I don't mean funny, haha, in the way that I can completely relate to what you're saying. When I was an intern, my first night in the neuro ICU, I just kept saying, oh, please let everybody be okay. No, please let everybody be okay. Because you're terrified. You are terrified. And if somebody asked me to go back now to the neuro ICU, please let everybody be okay. Please let everybody be okay. Because I would, you know, have not worked in a neuro ICU for 10 years. This is not a place I would feel comfortable in right off the bat. So, yeah, I think we're all in the same boat in that kind of way.
Even educating students has changed due to COVID and the whole pandemic. Because before, when we have our ICU program, we were able to fit everybody in one classroom, and you know, there's a lot of interactions between all the students and the teachers, and but because of the pandemic, we are limited to the 6 feet distancing per desk, and so we have to like accommodate all the students that we need to train by splitting up into 2 classrooms, and then we have to set up this whole thing with teams, so then we can, you know, present in one classroom and the other classroom can view the lecture at the same time. So that was a huge challenge because we've never done this before, in which we have to make sure that the other classroom can receive just as much information, and being able to ask questions and things like that. It's been really challenging. But then being redeployed too adds a new perspective. Because for me personally, I've never worked at LAC+USC, so it's a whole new, like, you know, ICU that I'm gonna be redeployed to. Plus, when I was working at Harvard, the last thing I saw was paper charting. And, you know, going back to the ICU, it's not even like riding a bike, it's like riding like unicycle, like Mike said, but also like, you know, with some new gadgets on there that I'm not familiar of how to use or how to apply my brakes when I needed them. So that was really challenging. But it also gives me a kind of a new view of what my students are going through day one in their clinical, you know, like, and what to expect from them. So that was a new perspective for me because I see my own struggles and I said to myself, oh my gosh, this is what the students are going through, and it is frustrating. It is very frustrating on all the, ORCID and then all the scanning and, administering medications, how many steps that it takes in order to administer a drip. It is insane. And now I could see that, how I can help the new students to struggle through that. So it really helped me to open my eyes about, their what they're seeing now.
Absolutely. Yeah, medicine changes. The way we practice in medicine changes all the time.
Yes.
Like I remember running to the ward and writing my order down and leaving, and now I just can kind of roll over and type it in, and that's kind of the convenient side of things. But then there's a whole other flip side as well. Absolutely. Yeah. Anybody else?
It's challenging. I mean, like you said, when we were practicing a long time ago, we did have charting, but it was much more simplified, much more streamlined. I feel it was much more the not the quality of documentation. It was the quality. Did I say that backwards?
Yeah.
It's not the quantity. It's not how much you document, but it's what you document. And I always say, and I don't know if you guys will agree, but I feel like now you touch the computer way more than you touch your patient. It's like 80% computer, maybe 20% your patient. And I feel like it wasn't always like that, It's unfortunate, but it's something that we teach our students. It's the way we are practicing now. I hope it goes back to somehow we find a balance, but who's to say?
It keeps evolving.
It does. I hope it evolves in a positive way, because going back to the bedside, I was like, my gosh, did I not just document this? So yeah, it is a different perspective in nursing, and throw the pandemic on top of it.
And we probably learned a lot from the pandemic on ways that we can practice medicine differently than we probably hadn't considered before.
Mm-hmm.
Now, coming back to Michael. Michael, can you tell us a little bit about yourself? You have such a fascinating history.
Well, I never wanted to be a nurse. Nursing found me. I was a truck driver. And, I had been a truck driver for about 10 years. And I was at that point in life where I was asking myself, is this all there is, is there something more you could be doing? And about the same time, I had a friend that was on Air 5. He was one of the sheriff paramedics. And man, he had like this really exciting life. And I'm like, that's what I should be doing. And he goes, Mike, you need to be a county trauma nurse. And I'm like, okay. I was the first person in my family to go to college. And he got me the application from the nursing school here, the county nursing school, and he said, sign up, you need to be a county nurse. And so I had no idea what I was getting into. So I graduated in 1993 with a diploma, one of the last groups that actually graduated with a nursing diploma. And, I came into the profession with the mindset that, wow, now I'm helping people, I'm really doing something great, everybody's gonna love me. And it wasn't exactly that way. And I remember in my first semester of nursing school, I was taking care of a patient who was a quadriplegic. And he did not physically assault me, but he did verbally assault me very bad. And I remember questioning, is this really the right thing to do? This isn't right. And that kind of stuck in the back of my mind. And then, I became a nurse, and I remember the first time I was working in surgical ICU, and there was this little old man leaving AMA, and the doctor asked me, please don't let him leave, he needs treatment. And I remember walking up to this little old guy with a cane and saying, sir, we need you to wait. And he turned around and hit me on the side of the head with his cane.
Oh no.
And I'm like, okay, this isn't right either. And so, the county way was always not to talk about stuff like this. It was to suck it up. You're a county nurse. Come on, tough it out. And so there were a lot of these things that built up over time. So then kind of fast forward, I worked in the ICU for 10 years, and then I became one of the ICU educators. And a little side job they gave me was teaching this assaultive behavior stuff, which I've never heard of. And it was crisis prevention, CPI, and it was interesting to me. And I kind of, I have to give a shout out to Tammy, because she's probably the most amazing person I've ever worked for. I've had a lot of jobs through my life. The support. And what is not captured maybe fully, in a podcast is the idea of nurturing people to do more. Not do more because you're assigned more, do more because you want to do more. And that's, as a boss, I'll call her really like a friend, but as a boss, she really made you want to do more, and gave you that license, great idea, let's do it. And so I kind of took the MAB and I took my ICU mind and started applying that towards it, and it just kind of has grown. And of course, in society, violence in the workplace has become, people have become more aware of that. It's always happened. And what I found out was a lot of nurses and doctors and healthcare providers were the victims of violence, either verbal or physical. And I still teach a little bit in the ICU and ER programs, but my passion has become the, helping staff stay safe. The legal requirements for this training are based in the shooting that took place in 1993 in Old General Hospital. It was after that shooting that California passed a state law requiring training in safety plans. So it really hit home, pardon the pun, and it made me reflect back on, what I experienced as a new nurse, as a nursing student, as a new nurse. And I started realizing, a lot of people have experienced those kinds of things. So I really have, I call it, to myself anyhow, the most important subject I've taught. And I will tell students I've taught about ventilators and vasoactive drips and, surgical procedures, but I still feel like this is the most important thing I can do, because if God help us, if a patient does come in and want to hurt staff, I take that oath seriously. And so it has all kind of come full circle, and it found me. I didn't ever purpose to be this, but it kind of found me, And so that's kind of where I am, and now I've been teaching and coordinating the assaultive behavior and the code gold and the BRT and all that stuff for 17 years now.
That's amazing. Having been a student in one of your classes, can you give us
now you're aging me.
Can you give us a little pearl as to what we can do to keep ourselves safe?
It really comes down to one of the things I've come to realize is we can't depend on others to keep us safe. We can't, depend on the sheriff's department or security, because even if they were standing right next to you, somebody could still do something. And it really comes down to being aware of your surroundings, being aware of what's going on around you. And we've heard this, all the time. And the other thing I've kind of recently discovered is, I think a misconception is we provide healthcare. Like the patient comes in and we do this for them. And I've really come to realize we negotiate. It's all day long. We are negotiating healthcare. They allow us to provide healthcare. It isn't like, do this because I told you to. It's like, okay, what is it you want? It's a great line in the Wolf of Wall Street. Sell me this pen. In other words, we tend to tell people what they need instead of asking them what they want. And if you start with what people want, that makes us safer, because we're giving people what they're actually looking for, not what we think they want. And so that would be my pearl of wisdom, I guess.
That's great. No, that's very helpful. You're absolutely right. We are in a field where we deal with people, and people have feelings and emotions and reactions, and we do too, and it's a dynamic between people all day long. That's what it is. I wonder if each of you could share maybe a special moment or time, something in your teaching where either a student or a patient, some meaningful interaction, either before or even during the pandemic.
I was a brand new educator at EdCos, and it was in fact my first class, and one of the students, she was good. She was doing a good job, but the only thing she lacked was confidence. And I remember her coming to my office. Actually, there were cubicles then, and she came in and she sat down and she was in tears, and she said, I don't think I can do this. She said, I just don't think I'm not good enough for this. I can't do it. And I knew she was good enough. Even though I was a new educator, I knew she was going to be good. And I said, yes, you can. And I just begged her not to quit, and told her what I saw in her. And she stayed. And it's funny, throughout the years, so that was 24 years ago, and throughout the years, whenever I see her, I always just get the good feeling. And when we were doing rounds last month, before, on the weekends, the admin was going around and talking to the different nurses, and she was one of the nurses I saw on my last Saturday there. And anyway, and I just, I was just so happy to see her, and she's one of the leaders in the ICU and everything, and in the MICU, and I don't know, that was what it was all about for me. So
That's very special.
I will say, when you teach, a new ICU nurse, they become your child, and when they do great, you're so proud, you're a proud parent, and it's kind of like what Tammy was talking about. I remember one of the nursing attendants in surgical ICU, who was an amazing lady. She went to nursing school, and she got hired into the ICU, and I remember being a preceptor for her, and she went on. She's currently a director of nursing at one of the other facilities, and there's still part of me that's like a proud papa, that my kid did good, and I think I can't speak for everybody, but I think I can, that you really feel like these are special people. They're not just co-workers or acquaintances. We're invested in them. And we also know that if we get in a car wreck on the way home, that might be the first face we see when we open our eyes, So we take it, I think, really serious in that sense too.
Like Sam, being redeployed has given me a different perspective. So now when I go into we just got redeployed, came back to teach. We actually got redeployed, and then the very next week we came right back into our previous role. So with that new perspective that I have, I try and tell the staff, the new ICU nurses, especially ones that we just had, that it's such a privilege to come and work here in the ICU, and they shouldn't take it for granted. Some of them come in and they're like, oh, my preceptor thinks of me like this, and like the world is against them. No, we're here to help you succeed and give you the tools to succeed, and we want to see you succeed. And the ICU isn't for everybody, and that's okay. There's nothing wrong with that. I always tell people things happen in your life for a reason, so go ahead and follow that. But to have that perspective of we are privileged. The patients trust us. They trust us to take care of them, and we have to be competent, confident, secure, and hopefully we in the education department guide them in that, provide them the tools and the knowledge and all of that. So I try now bring the perspective of it's a privilege and we should view it as such.
And to add to what Beth said, we were talking about that New York Times article, And I don't think we could get through it without like crying because, you know, we were there present with all these patients. And so one of our other coworkers asked like, well, what could we do? You know, what could we do for these patients? And I said, Yvette, let's keep doing what we're doing. Each day we come and we try to do our very best, and we try to, like Beth said, and Sam and Mike, impart all of Stephanie, Tammy, Deborah, impart all this knowledge that we have and share it with them and find ways of how can I best teach you? How can I best, approach this whatever topic it is, and finding ways. And I think we rose to that challenge, you know, doing it remotely, recording, doing various in-service live. I mean, Beth and I did an in-service where we would lug around a huge TV and we would line everybody up, you know, outside the nurses station and just, you know, start doing an in-service. And so we're always, you know, thinking about our patients, because I said, this is what we do, this is what we excel at, and each and every person here has such passion to you know, like I said, proud parents, you know, because you're like, oh, I helped. And at the same time, I have to say, I've learned things too from the new students. I've learned to look at things a different way. They question, and I'm like, I've never thought about that. That's a very good question. Let me see. So it also encourages us to greatness, you know, to be the best that we can be.
Yeah. You know, I wondered, this is a teaching hospital, and we have all different kinds of disciplines who have students that come along. I did my residency here, I did my fellowship here, and I remember, especially when I was an intern, oh man, did I rely on the nurses every day. And there was more than once when the nurse was like, I think, doctor, you meant to write that. And I was like, oh yes, you're absolutely right. Thank you very much for that. So can you talk about a little bit of your experiences with our other, you know, colleagues, not just our nursing colleagues, but with others, maybe the interns, doctors, how you are part of their education as well?
So the surgical residency program. See, we had surgeons from all different backgrounds. They came from the military, from Kaiser, Cottage Hospital. And I remember there was one of the surgeons who came through. We kind of developed a little bit of a friendship. And he was interested in plastic surgery. And so he went on to become a very successful plastic surgeon in Beverly Hills. And I went by to see him one day. And I'll never forget this. I stopped by his office, and he ushers me into his office, and he had a colleague in the office with him. And he introduced me to his colleague. He said, this is Mike. This is the guy who taught me how to be an ICU, you know, take care of patients in the ICU. In other words, he didn't see me as, well, this is a nurse and I'm a doctor, but he really saw it as a colleague. And I feel like I don't know any other place other than county, and so I don't know what it's like for other nurses and doctors and their relationships, but I know here at county we're definitely a team, and we look out for each other and we help each other, and that's why I've been here 27 years, and well, what did you say, almost 150 years? It's why people stay here. Yeah. I think is because it is such a team. You know, that's what's so attractive about it.
Just this last time when we were redeployed, we had, gosh, I feel we've been here so long. The new doctors are so young. Oh my gosh.
And they're getting younger every day.
I know. So she wanted to put a Dopphoff on this COVID patient. So she's like, I've never done it before. So Ramona, our fantastic ICU nurse, was like, okay, I'll help you. So she puts this Dopphoff in, and it's weighted, you know, and there's a guide wire. So she comes back the next day, and she's like, there was a guide wire. And I was like, oh yeah, we took it out. She was like, oh, I was hoping you did, because I had no idea what I was doing. And I was like, you need to order this afterwards so that we could, you know, and she's like, okay, I'm on it, you know. So It is, and you know what? It's a trusting relationship. It is because then they trust you, they trust your eyes, they trust your ears. So when you come to them with an issue, they're like, okay, let me address the specific issue you're dealing with. And it is, I truly feel like it's collaborative. It's truly collaborative, especially here. Like, I've never been like Mike anywhere else. So it's great. In surgical ICU with our surgeons, it's truly collaborative.
I definitely felt that way in burns too, and particularly with peds. Oh my goodness. We relied so heavily on the peds nurses and doctors, residents, and they were always there. All we had to do was pick up the phone. We've got a little infant. They would be up there. They never acted like it was a burden at all, no matter how much they had going on in peds. And they were there the whole time, as long as we needed them, and you could just feel the anxiety drop as soon as they walked in the door, both the PICU nurses and the doctors. The one thing I would like to say is about this team. I have to say that everything that's ever been asked of them, everything I've ever said, we need to do this. I get the call from admin, this is what we need to get done now. They always rise to every challenge, and do it so well. Because they do, as Julie and Mike said, and all of us, they have such a passion for teaching too, and taking care of our patients. So going through this pandemic, it was, class after class, and in services and everything. And as Julie said, pushing the TV down the hall, whatever's asked of them, they did. And then to be redeployed too, it was so hard to know that had to happen, but then they did. And then and they always do. And I just have to say what a blessing it's been to be with this team, and so I'm just honored.
Well, thank you all so much for being here today, and thank you for everything that you have done for our patients, for our colleagues, for each other, and what you continue to do. So thank you.
Thank you.
Thank you for tuning in today. Make sure to follow us on Instagram and Twitter, and to subscribe to the LAC+USC Medical Center YouTube channel, where you can find all of our previous episodes, in addition to the episodes located on anchor.fm/House Calls with Dr. K. We also want to hear from you, so email us at lacuscpio@dhs.lacounty.gov. Thank you for tuning in, and see you next week.